Well, as you probably heard on the news, the World Health Organization has declared a international public health emergency as a result of the coronavirus, the novel coronavirus 2019 outbreak in China. And this is the electron micrograph of the coronavirus. This isn't the novel one, this is an older one, but it's kindly released by the Centre for Disease Control, so we can actually visualize these tiny particles with the electron microscope. So let's think about what's going on. Now, what we want to do in this video is think about this from the perspective of the evidence base. Now, the evidence base, to my mind, comes from two parts, because it's only the evidence base that separates us from witch doctors. Science and medicine and everything, modern things, have to be evidence-based. And there's two aspects to this. One is empirical evidence. Now, empirical evidence means taking information from the ground, from the field. So empirical evidence gained in China about patients with this condition and in other parts of the world. That's one line of evidence. But because we're still learning a lot about this virus, because there's a lot of things we don't know, we can also inform our thinking with application of theory that we already know about infectious diseases from other conditions. And I want to kind of combine those two together, and hopefully this is evidence-based. We don't want to be alarmist, but we don't want to miss a very significant outbreak either, so we need this kind of balance. So you probably know that Wuhan, China, December 19, a cluster of patients with pneumonia were identified. Now, pneumonia is a severe chest infection at the level of the alveoli, when the small alveolar air sacs will fill up with inflammatory fluid. And this is a bronchopneumonia. It affects both lung fields. You can get a lobar pneumonia that just affects a lobe, but this affects both lung fields. It's a bronchopneumonia. And a previously unknown coronavirus was discovered. And this is pathogenic. Pathogenic. Now, path means disease, genic means beginning. So a pathogenic virus is one which is capable of causing disease. And that is what is causing this disease that we're currently having an epidemic of in China. And what we're really hoping we don't get a pandemic of all around the world. Now, here we can apply some basic sort of epidemiology. Now, there's a concept in epidemiology called R naught. R naught. And this is the basic reproductive number. And with the new coronavirus, this is estimated to be 2.2. SARS was 3. Now, what does this mean? Well, what this means is that on average, one person who has got the disease with this new coronavirus, based on the current data, will infect 2.2 people. So we have one person who starts off with the disease. This could be in China or it could be in a new country. This first person, person one, is called the index case, the first person. And on average, they're going to infect 2 people. So they're going to infect 2 people. Actually 2.2, but it's harder to draw. So they're going to infect 2 people. So the 1 becomes 2. And on average, each of those is going to infect another 2.2. So we've now end up with over 4 people. And again, they're going to infect an average of 2 each. So now we have 8 people infected. And on average, they can infect, I think you get the idea. So what we're saying is that the typical person with this infection is infecting, on average, 2.2 new people with it. Now, SARS in 2003, the severe acute respiratory syndrome, that was 3. So this preliminary data is actually showing that SARS is more infectious than the new coronavirus. And in a way, that's very encouraging, because SARS was essentially contained. SARS did spread around, but we didn't have a massive pandemic and mass fatalities from SARS, so it was contained. So it shows this can be contained. But one of the problems is there's already been a lot of travel out of the infected area. Now, I don't particularly like flying, but sometimes you have to. And aeroplanes are just such stuffy places. You're sitting right close next to someone, and obviously, especially like me, you fly economy, of course. You're right next to people. They can be coughing and sneezing and breathing and spluttering and snoring. And they can be giving out all sorts of organisms. And even when there's no epidemics around, I always get an infection when I've been on the plane. I'm always coughy or sneezy afterwards. I always seem to pick up some respiratory bug as a result of my air travel. And the airlines might correct me on this, but as far as I know, only 50% of the air in airlines is new. The rest of it's recirculated. So the air's getting circulated quite a bit. So travel is taking place via sort of these mobile aluminium tube incubators called aeroplanes. But then people, of course, can drop off all over the world. Now, there's been 2 cases of coronavirus confirmed just today in the UK. Our chief medical officer will not tell us who they are. We believe they're from Yorkshire. We don't actually know. He won't tell us what nationality they are. He won't even tell us if they've flown into the country, although we believe they have flown into the country. So quite a bit of... I suppose he would say it's confidentiality, but there's a public health interest here as well. So that's what's happening. And they've immediately been whisked off. This is the point I'm trying to make. They've immediately been whisked off to a specialised unit in Newcastle, where they have equipment that's as good as any in the world, and they'll be isolated. And that will contain the spread, I'm sure. Be very surprised if it gets out from a secure infectious diseases unit in an advanced Western country. But the problem is, people can also travel to poorer parts of the world with less established health systems. Now, I'm not going to pick out any country, but there's lots of countries which have great deficits in public health and great deficits in individual healthcare. Many poorer countries and many poorer people who don't have the access to the healthcare, and the facilities simply aren't available. So what can happen is people will travel from infected areas to a less developed area without a health system that's going to identify this. And they can get sick, and they can infect lots of new people, giving rise to a spread to the pandemic to a poorer area of the world with a less developed health system. And then, of course, from there it's going to spread out. This is why health is not localised. Health respects no borders. It's very international. The coronavirus isn't going to say, "Oh, we're at the border now, we better stop." It's just going to carry on. So a large reservoir of infected people could develop in a poorer country with a less developed health system, which can then travel to other areas of the world. That, to me, is the big risk in this situation. This is why it's so important to try and level up healthcare systems around the world, although we are a long way from that situation. So that is the big risk. Travel via poorer countries. That will spread to the rest of the poorer countries, to other poorer countries, and of course it will spread to Western, more advanced countries, UK, US, Canada, Australia, Europe, potentially as well. That is the fear. So let's keep to the evidence. What do we know? 3 main articles published so far. There's 1 in the Lancet and 2 in the New English Journal of Medicine. And I will put the links to those below, and I would encourage you to read those to get the definitive information in case I've misunderstood anything. But the first 425 patients with confirmed novel coronavirus with infected pneumonia. Now, these are the patients that presented to hospital. So these were the more poorly patients. So in research, we would call this a self-selecting sample. So it doesn't mean that everyone who gets this condition gets pneumonia. As we'll see, we're hoping that there's many very mild cases. But this was 425 patients. So this is a novel coronavirus infected pneumonia. And the first thing we see is that a lot of these people were fairly old. They were 59 was the median age. And this is... okay, we could say this is somewhat encouraging because it's looking like younger people might be more resistant to it. We don't know that yet, but it's looking that way. Now, this is interesting because classically with influenza, people that have underlying disease conditions like chronic obstructive pulmonary disease or unmanaged diabetes mellitus or heart disease where they have lung involvement are more likely to get the complications of influenza and potentially die from that. And that's tragic, of course, but these people are already ill. So to some extent it's to be expected. But in the 1918-19 influenza pandemic that we call the Spanish flu in the UK, I think they call it something different in Spain, but there was this epidemic of influenza caused way more deaths than the First World War. It started at the end of the First World War. It went on to 1919, so 1918 to 1919. And what happened there was it was killing older people, as you would expect, but also it was killing young, fit people because the immune system generated an inflammatory reaction to the 1918-19 virus. And that inflammatory reaction caused the lungs to fill up with fluid. So that was bad. But it looks like the pathology here is caused more by the virus than by the inflammatory reaction to it. So the people most at risk from the current data are older people with an existing health condition, which is good because, well, it's not good, it's terrible, but we don't want younger people to be infected, and we especially don't want children to be infected. Now, the early cases were from the Hunahan seafood wholesale market in Wuhan in China. Now, this is a bit of a euphemism, really, because these markets sold live, captured wild animals, because the viral reservoir for this is in wild animal populations. It's a zoonosis. It's spreading from animals. Now, I don't want to talk about the ethics of this. You know, to my mind, and I'm sure to many of your mind, this is outrageous that you would capture and eat wild animals. We're not hunter-gatherers anymore. We don't need to do this for food. But that is what happened. So the initial cases were from there. So that's probably direct zoonotic spread. But then in the later cases, and this is just of these first few hundred patients that we're talking about, 8.6% of the subsequent cases were from the link to the market. So as the epidemic developed, a smaller and smaller proportion of the individuals affected had direct exposure to the animal reservoir. This means there's person-to-person spread. So we can now be sure that there is person-to-person spread. Now, I did a video just recently on the pathophysiology of infectious diseases. And we looked at this incubation period, which was from when someone is first infected, the point of infection, up until this point here, when they first get the illness. So this red line is when they first get the illness. So here they feel a little bit sicker, most possible sick there, then they start getting better. So this phase under here is the period of symptomatic illness. So this incubation period here from point of infection to onset of symptoms is the incubation period. And just a couple of days ago we weren't sure how long this was, but now we know that the mean incubation period was 5.2 days. So our initial assumption that we've been working on was 2 to 14 days, and it seems that that is not too far out. Now, in only 5% of the cases did they incubate for longer than 12.5 days. So 14 days quarantine is needed. Now, a few cases, a very small minority of cases, might present after 14 days. But 95% of cases that are going to develop the infection will do so in 12.5 days. So the UK government, for example, is using 14 days quarantine for people flown in from the epicentre of this infection in China. So 14 days are needed. And I have heard some rumours that other governments are using less than 14 days. Well, let's hope they change that very quickly, because this is now based on data. We know that 5% of cases are going to present after 12.5 days. So the quarantine needs to be at least at least 14 days. And in its early stages, we now know that the epidemic doubled in size every 7.4 days. Every 7.4 days, we were getting a doubling effect with this R naught phenomena of the index of spread and the transmissibility of the virus. Now, of course, this R naught figure is only an average. We can massively change this with public health measures, of course. This is what we're trying to do. So if the R naught is less than 1, then that means every infected patient is infecting less than one other person, and the number will gradually decline. But if the R naught figure is greater than 1, then it is going to spread, and we think it's 2.2 in this case. Now, the paper in the New English Journal of Medicine is saying that human-to-human transmission has occurred amongst close contacts. Quite what that means, I don't know. Family members, we certainly won't want to be kissing or cuddling people with potential infection. Certainly wouldn't want to be sharing utensils with them, and we wouldn't want to be near them when they were coughing or sneezing, because, as we've said, there's like a 2-metre spread. But I think what this means is it's not spreading in the street. So we don't want to be alarmist about this. It does seem to be close contacts that are being affected. And the 2 people in the UK that have developed coronavirus infection today, we know they are from the same family. So that is consistent with this data. And so far, in those initial cases that we have from China, where we have the data, of course, we don't have all the data of I think it's getting on for 8,000 cases now. We don't have all that data. But in that initial data, no cases younger than 15 were identified. So this is encouraging. We don't want our children to be getting this infection. We certainly don't want our children to be dying. The Chief Medical Officer in the UK today has confirmed that the death rate from this virus is about 2%. That's his understanding of all the data. The initial data that I had from China was 2.2%. So the Chief Medical Officer in the UK seems to be going with that figure. Remember, SARS was quite a lot higher, of course. SARS was 10%. So some grounds for encouragement here. No cases younger than 15. And it may be that younger people have fewer symptoms as well. It was a young child who they believe was an asymptomatic carrier who might have spread the infection, but who didn't seem to be suffering from symptoms himself. Now, that's good in that children may get a milder form of the disease, but it's bad in that they might be shedding the virus, breathing out the virus during the incubation phase. Again, we're not quite sure about that yet. We're not quite sure about that. SARS didn't shed well in that stage. In fact, I don't think it hardly shed at all in that stage. It was just people that were actually ill that passed on the virus. Whereas influenza does. Influenza certainly does. You can catch influenza from someone who's completely asymptomatic. So at the moment, we're not quite sure. I suspect that, unfortunately, it may spread during the asymptomatic incubation phase, but we don't know yet. That's right. So the child who had this, who didn't seem to be ill, was shedding the virus, although he wasn't ill. So it's good that the children so far don't seem to be badly affected or have mild cases of the disease. It's bad in that they could act as vectors of disease, having the virus but passing it on to us older people, even although they have no symptoms. So that is the risk of that. Now, we've talked about these patients with pneumonia and severe pulmonary complications, so they don't get enough oxygen and become hypoxic and need oxygen and ventilatory support. But the initial data, again, is showing that many people infected had a mild illness. Again, this is good, because if someone's infected, has a mild illness and then recovers, they will be immune. Because remember, on this other video, we noticed that people make these antibodies. The number of antibodies goes up. And the antibodies are the immune proteins that are protecting us against this disease. So once the person's got these antibodies, they're going to be immune. That's why we want to make a vaccine, of course, because the vaccine would make us immune without having the disease, but we haven't got one yet. So it's good that it was a mild illness, but again, it's bad because people might just feel a bit off, still going to work, and of course then they're spreading it. So there's kind of good and there's bad things about that. I think I'll leave that video there for now. That's a bit of an update. In the next one, we'll talk about more about the culture and transmission of the virus.